All right, why don't we get started? Afternoon, everybody. Thank you very much for attending. My name is Matt Roberts. I'm the program director here in Ottawa, and I'll introduce myself a little bit more in a second. But again, welcome to our first ever uOttawa Urology Virtual Open House. I know you're probably accustomed to doing pretty much everything this way, but certainly for us, interacting with our students and applicants, this is a new thing. So I've been looking forward to it, and hope you enjoy it and find it useful. Great. So again, I haven't met most, if not all of you before. So who are we? Who are you? Who's talking to you today? Well, first of all, I think there'll be a large number of our residents and faculty here today on the line. Myself, I'm the program director, so I'm been doing this for about 3 years. I did my medical school in Toronto and my residency here in Ottawa. Came back on staff about 10 years ago after doing a 2-year fellowship in male fertility, and did a Master's of Education at the same time, both in Toronto. So trained here in Ottawa, know the program well, was part of it all throughout. And then, like I said, I've been the program director for the last 3 years. The other people who you'll be hearing from today, Jim Watterson, Dr. Watterson. So he was the previous program director, my mentor in this role as well. Currently, he's the vice chair of education for the entire Department of Surgery. So he oversees education in all surgical divisions. So he has a unique perspective on that. We have Ravi Kumar, who's our PGY4 resident on our selection committee this year. And he's going to speak to you as well. He is the brain trust and the driver behind all of the social media content you may have seen, our website and this presentation. So Ravi's done a tremendous amount of work to put all this together. And then Kristen McAlpine has also contributed immensely to the open house and to all kinds of other things we've been working on. She just graduated in June. Is down in Toronto doing a urologic oncology fellowship right now and a master's degree as well. And she'll speak to you as well. And we also have a variety of other people who I think I'll let introduce themselves as we go. I'm going to give you some thoughts as well. So I'll go through some of the sort of, let's say, technical things about our program. Again, if you'd been here, these are a lot of things you would see, but certainly some highlights that I want to share with you. So as most programs are in Canada, we have a 5-year fully accredited program here. Typically, we have 3 to 4 residents per year. This year, we are having 4 CMG spots and no IMG spots in the first round. I just thought I'd let you know about that. And currently in the program, we have 20 residents, so about 4 per year. So the training programs carried out mainly in our 2 adult hospitals, which is one hospital called the Ottawa Hospital with 2 large inpatient sites, the general campus and the civic campus. So that's where our residents spend the majority of their time. You go to the next slide. And at each campus, the urology services are arranged into sort of different subspecialty areas, and this was by design. At the general campus, we have 4 urologic oncologists and the transplant, endourology, and MIS services there as well, with 4 faculty. I've listed their names there, I won't go through them one by one, but 2 large services at the general. At the civic campus, we focus more on both reconstructive urology, both male and female, reconstructive urology, and men's health, including infertility and erectile dysfunction, etc. Also, both campuses, there's quite a lot of general urology that goes on as well. And then we have a 3rd site within the Ottawa Hospital called the Riverside, and this is an outpatient hospital, so no inpatients there. Most, if not all of us, will go there periodically, once or twice a month, to do OR cases, and the residents will come with us there. Mainly TUR, endoscopic surgery, ureteroscopy and stones, and some other more minor scrotal surgery. That's also where shockwave lithotripter is. So these, this is sort of located near the general, but halfway in between, and it's sort of a day trip when we go there. In Ottawa, there's a dedicated children's hospital called the Children's Hospital of Eastern Ontario, CHEO. Currently, we have 2 full-time pediatric urologists. Our third retired recently, and they're actively recruiting a third. And here they have the full service of pediatric urology, outpatient clinics, ORs, and dedicated pediatric emergency room. This is located right next to the general, so very, very close by as well. And what do we do? Well, of course, we do all the gamut of urology, and I'm going to go through some of that in a second. Some of the special programs that we have here that our residents benefit from are a full robotic surgery program for radical prostatectomy. As mentioned, shockwave lithotripter, which is not available in every site, and what we call our walking wounded ureteroscopy program, where stone patients get dealt with in a sort of rapid access fashion. That's all done at the Riverside. We have a very busy kidney transplant program, which maybe uniquely is run exclusively by urologists, by our division, the 3 members in our division. And that gives our residents a very large exposure to renal transplantation. As mentioned, pediatric urology, one of our faculty is focused on female pelvic medicine and surgery and reconstruction. We have a full spectrum of men's health and reconstructive urology. As I mentioned at the beginning, I do male infertility. We have someone else dedicated to urethroplasties and artificial sphincters, penile prostheses, so all of those sort of subspecialty areas. And more recently, outside of our main sites, there's a variety of smaller hospitals in the periphery of Ottawa that traditionally are independent, but as things change with delivery of service, several of us go out to these centers. I was at one yesterday and brought one of our junior residents with us to do sort of community-based type procedures and clinics and so forth. So those are sort of the resources and some of the special programs we have. One of the frequently asked questions that came up on the when you registered, so I threw it in here, was what are your case volumes? What does that look like? What's the open surgery exposure like in Ottawa? And so Dr. Watterson compiled for last year, so January to December 2019, our case numbers for a few select procedures. So this chart here shows you, for example, open oncologic surgery. If you look at the top 2 rows, that's about over 50 cystectomies that were done. If you look at nephrectomy, partial, and nephro-U, this is all open. You total that up, you get about 80 open renal surgery cases. Second last row, 2 of our faculty continue to do open radical prostatectomies, so our residents get exposed to that still. I think that's a very common question that we get a lot, is what about open radical prostatectomies? So we do have training in that. And even though it's not an open procedure, I put robotic prostatectomy here to show you there's a very large volume of robotic prostatectomies that go on as well. So next slide, that's sort of our open exposure. Typically, it'll be our more senior residents who will get involved as the primary operators in those. So if you take, say, 80 renal surgeries, and we have 4 chief residents and 4 fourth-year residents, you can get a sense of the participation rate on an annual basis. If you go to the next, so this is laparoscopic surgery. So 172 laparoscopic procedures done last year, obviously mainly renal surgery. So very large exposure there. Many of us do laparoscopic surgery of different types. Next. This is a bit of the bread and butter kind of endoscopic exposure that you would get here. If you look at the top, ureteroscopy, for example, last year, 850-ish ureteroscopies done. So that's a huge number, and typically, I'll go through this in a sec, our PGY 2 and 3 residents would be doing the majority of those. So very large volume, very high volume of PCNL, percutaneous kidney surgery. And then the second part of the chart there, the sort of bread and butter urology endoscopic cases, TURPs, bladder tumors, over 1,000 of these. And again, our junior residents typically will get a lot of exposure to those. Just a list of other sort of reconstructive and men's health type procedures. These are lower volume, obviously, but we offer the full spectrum of subspecialty training in all of these procedures. And kidney transplant. So I mentioned this before, even though the vast majority of residents and graduating residents will not do kidney transplants in their practice, number one, there's a huge number of surgical skills that can be gained by participating in these procedures. I did them too when I was a resident, and don't do them now, of course, but just working around vessels and certain different types of incisions. So we have this exposure for you that I think is really, really great. And like I said, fully sort of internal to the Division of Urology, and even things like CAPD catheter insertion, which is a minor laparoscopic procedure. You get lots of hands-on exposure to something like that. So that's our surgical volume. We can, if anyone has any specific questions, of course, we can get to those at the end. But we always say that we're a high volume center. We have lots of cases going on all the time, and I'll go through who does those as I get further on. How do we organize our program? It's still organized in the traditional PGY 1 through 2, 3, 4, 5 way, and that's true of, I think, all programs in the country. You may have heard of the CBD model that's put out by the Royal College that all programs now use. And this is basically a plan of progression through stages of training based on competency, meaning you don't just automatically move from one year to the next based on spending 12 months. You do, by label, you will go from year to year on a 12-month basis. But really what marks your progression is marking of competency. And so this is called the competence continuum. If you look at the bottom, you come in as a PGY1 resident, but essentially the first 2 blocks, and I'll explain blocks in a second, you spend in something called transition to discipline. So on urology, just basically getting up to speed on some basic things, and that takes basically the summertime. And then the remainder of PGY 1 and 2, you're in a phase called Foundations of Discipline, where you're doing the basics of clinical and some basic procedural skill acquisition. Core of discipline is the sort of more senior resident level, doing vast majority of the surgical procedures as you go through, and all the other clinical requirements, other things like research, teaching, and so forth. And then the last phase, transition to practice, is honing skills that will allow you to be an independent urologist, practicing out there, things like practice management, et cetera. So that's, we get questions about this a lot in terms of, will the CBD sort of plan change the length of training? Short answer is no, and I think that's true of all training programs in Canada. And it's sort of it's more of an overlay on the traditional PGY sort of system. So we can go to the next. So what's PGY1? I think you're probably interested in the whole residency, but certainly this is the most to the moment question. So our first year residents do a variety of things. Here in Ottawa, the year is arranged in blocks, 4-week blocks. So there's 13 blocks a year. It's not months, it's blocks. But essentially they'll do 5 blocks of adult urology and 2 of pediatric urology. So just over half the first year is done in urology. And that includes the summer where all the incoming residents are with us for blocks 1 and 2, get transitioned over, get up and running and so forth. And that's not been the way it's always been. And I think it's been a great change. It's gotten everyone sort of acclimatized and know everybody else. 2 dedicated blocks of pediatric urology. You do call in pediatric urology throughout your residency. So we felt it was important to get some baseline skills right at the beginning. And then the rest is in nephrology, general surgery, emerg and ICU, all very relevant skills to have. Also important for something called surgical foundations, which you may or may not know much about. But if you're a surgical resident in Canada, there's a parallel program you go through in your first 2 years, where you go through a variety of general surgical type things and need rotations based on that. And just a note, our program, at least currently, is American board eligible, or would make you eligible. So some of the rotations have to be geared to that. So what does a PGY1 resident do here other than go through those blocks? Obviously, you're going to learn the function of how we work at the beginning, clinic, ward, and emergency, especially if you're from elsewhere, which most people are. Spend a lot of time traditionally in the clinic, ward and emerge consults. Right now we are have a partial virtual and partial real clinic exposure. Obviously, that'll change as the years go on, but traditionally our first years will spend a lot of time in our clinics with us. Procedures, you're definitely going to get exposed to lots of bedside emergency procedures. The senior residents help with learning of that. Spend a lot of time in cystoscopy clinics, so getting your hands on right from the get-go, doing those types of procedures. And certainly getting into the operating room, often as a second assist, getting to know how the instruments work, doing small parts of the procedure. So definitely some hands-on right from the beginning that you have with us. All our first year residents are on call, of course, but always backed up, so you're well supported, both by the resident you're on with, but probably someone will speak to this later. You're going to be backed up by everybody. And then you're fully integrated into our program right from the get-go. We have academic half days and so forth I'll talk about later. So to attend all of those and be part of the program even when you're off service. So that's what a PGY1 does here. What I think some of the particular strengths are that sort of immediate immersion in the program, blocks 1 and 2, are focus on getting you involved in things right away, including procedures and in the program as well with the half days. Second year is about split between urology and a variety of other surgical things that again are required and are also very helpful for your skill development. I'll just point out in particular, in second year you get 1 block of community urology elective, so you can basically go wherever you want. Purpose, get a little bit of a different view of urology outside of the academic center. Some people go back to their hometown, others go other places. We have connections all over the place. And I think, even though it's a bit early at this point to make career decisions, it just gives you sort of a perspective on somewhere outside your training program. So I think that's a really a particular strength. As a PGY2, and I think this is also probably fairly unique to our program, we start getting you pretty heavily involved with surgery at this level. Many transurethral sections, so bladder tumors, TURPs, ureteroscopies, and also bedside assisting for robotic prostatectomy, for example. So getting hands involved with laparoscopic procedures. Our second year residents get heavily involved with this. When I went through this program, I did 3 months in first year and none in second year of urology. So you showed up as a PGY3, never having really touched an instrument, to be honest with you. And currently our PGY2s come out of that year with all the baseline skills to get going on their more senior years. So I think, and someone, one of our residents will reflect on that later. I think it's really a unique feature to our program. You're doing senior resident call and continue to sort of transition through some of the stuff you would have done as first year as well. And third to fifth year is basically all urology all the time. You go back and forth through those services I showed you earlier, the 4 sort of subspecialty ones. Here's where you spend 3 dedicated months at the Children's Hospital and do your training there in the OR and the clinic. In fourth year, there's 3 elective blocks, which basically means you can go outside of Ottawa to do typically to community centers. But could be other places to get both sort of some skill development, but more for career planning, see what kind of practice you might want to have, geographic location, and so forth. There is an option to make one of those blocks a research block as well for those who are very involved in research. And then in third year, there's a 1-week exposure where you're go with one of our colleagues, Dr. Mahoney, up to Iqaluit for a week where he runs a clinic in minor ORs and sort of get a little taste of that sort of remote urology kind of practice. So that's what your third to fifth year sort of structure is. Our third years, we call this the endoscopic year. They're doing TURPs all the time, stones. I would say the third year residents are probably of all in the OR the most in terms of days because there's so much of this stuff going on. So really get a great base of skills at the beginning and are very, very competent by the end. We'll often leave the third year residents to do these cases independently once they get up and running with them, even near the beginning or mid PGY3. Fourth year is sort of a transition year where you're doing some of those still endoscopic procedures for sure, but really getting involved in some of the bigger procedures. For example, for a laparoscopic nephrectomy, fourth year resident would put in the trocars, learn about positioning and so forth, put the trocars in, do some of the bowel dissection. Chief resident takes over to do the main part of the hilum or taking the vessels, and the staff may help there once in a while, and then hand it back to the PGY4 to do the last bit. So certainly we get you involved there. Some of the electives, like I mentioned, happen in this year. And one of the roles that I think is really helpful for training and for learning some important skills is our fourth year residents, really the team manager. They're working on schedules for all the residents, organizing the week. And these are all skills that you need over and above how to do the surgery when you're going to be a urologist. So the PGY4s have a lot of responsibilities and a lot of exposure as well. And our fifth year or chief residents are basically doing all those big open and laparoscopic procedures, PCNL, et cetera, on top of still being involved in the clinic rounds and on call. And near the end, again, are focusing on their transition to practice, at the same time preparing for the Royal College exam. So PGY5 is a busy year. And as I mentioned, there's 4 services, 2 at each campus. Basically, one is quote unquote in charge of each one, and they rotate sort of 3 blocks each through each of the subspecialty services as a chief resident. Just gonna check my time. Good. So our academic teaching program, I think, is very robust. It's been in place for many years and modified year to year as needed. Dr. Watterson, Dr. Oak, our chief of urology before him, and set all this up as well. So we have an academic half-day schedule every Monday afternoon, and these are all faculty-led, so you'll have an expert teaching you. Just direct your attention to the bottom of the slide. If you want to see the whole schedule, it's on our website. If you go to that part there, Ravi has uploaded the whole schedule for this year, so you can get a sense of the topics we cover. But basically, we cover all the topics on a 2-year cycle. And again, I think staff-led is very, very important, where you're going to get experts teaching you these things. We have weekly Wednesday morning rounds. We cover a variety of topics. The residents will often lead that, giving a presentation, M&M rounds, et cetera, interesting cases. Guideline and AUA update reviews are done mainly in the summer on Monday afternoons. We kind of do a sort of more relaxed academic schedule through the summer, but still protected time. We have some overlay additional lectures from radiology pathology. We have a surgical skills curriculum, which I'll show you in a second. We do a monthly journal club, which is both educational and fun. Typically, we usually do these at a restaurant off-site in the evening, have dinner. Residents present journals, staff supervisors. Right now we're doing it all virtually, but I can tell you we're all looking forward to the day when we can get back to do our usual journal club. I think that's one of the things we're known for here. And I put this on specifically through the teaching program. We do 2 of our own practice exams and run you through the American Urologic Association exam as well. And this is both obviously for assessment, see how you're doing, and check your knowledge, but also good practice for the Royal College exam. I think one thing we pride ourselves on is our resident success at that exam. I think most of the work is theirs, hard work they put into studying, but I think the program supports them well in terms of getting them ready, doing some practice exams, and certainly feedback on how they're doing. This is an outline of our surgical skills curriculum and manual that Dr. Watterson put together a few years ago. In Ottawa, and I'll show you some pictures in a sec, we have a skills and simulation center, which is really sort of state of the art and has been around for a few years. And we developed this list of labs that we do with the residents basically every year. And in the lab, get some skills on these things. Some of these are basic things like how to use a cystoscope. And for example, the PGY1 residents would do that. Some of them are advanced, like percutaneous nephrolithotomy or laparoscopic surgery, where the senior residents would do those labs. So it's usually a small group of learners with 1 or 2 mentors. We do a porcine live pig lab. We use animal models and as well as sort of low fidelity models, a mixture of these things to go through some of these skills. And it gives you that extra time to practice, learn about the skills, and get some feedback right on the spot. Just some pictures of the lab. There's a variety of areas in there. This is a laparoscopic box trainer lab, for example. Next slide. Yeah, and there's anyway, there's a 2 or 3 procedural rooms. There's also some areas that are basically look like real ORs where we, from time to time, will run a sort of high fidelity simulation with other services and so forth. Another common question that came up on the frequently asked questions was, what about resident research? So, you know, the basic requirements if you're here as a resident is you do 2 research projects a year, during the residency. And the idea is start to finish with a manuscript prepared. Every project is mentored by faculty, and these can be of small or large scale, depending on your interests, your skills, and career goals, and so forth. And how does that work? Well, that we have a lot of supports for resident research. We do an annual brainstorming session. We have a dedicated resident research director, Dr. Kagianos, who sort of oversees all of the research projects and directly, in addition to the faculty mentor. Several of our faculty are very active researchers with dedicated time, lots of expertise and methodology training. So for those interested in doing high impact research, we definitely have faculty with the skills and support for that. You present your projects at our own research day, Department of Surgery, and any work that's accepted at conferences, you get to go. You can go and present your work in national, international. There's funding for that. And I think that's really important. That's one of the things I remember about going to a few conferences, and there's fun there, and presenting and making connections and so forth. So that's the basics. I have another bit later on in the FAQs about resident research. And teaching. So we, myself certainly, and I know Dr. Watterson before me, we've really encouraged our residents who are interested to get involved with teaching our medical students. They're often on service, obviously, to teach on the ward. We have a variety of lectures and skill sessions that we're asked to do. I'll often bring a resident with me, or if appropriate, they'll go and do it on their own if they're really interested with our students. And some other sort of peripheral things like SEED, the surgical interest group things, careers night, basically always have residents who are interested involved. Not everybody's interested in this, but certainly I always throw out an email if I'm invited to one of these sessions, and I get many responses of people interested. So we get you involved in teaching. And some other highlights, and I kind of wanted to go through the technical stuff, but some other thoughts. We have a very collegial working environment here. We focus on teaching and mentorship of our residents. I think all of our faculty and residents, on top of the teaching, are really dedicated to patient care. I mean, that's at the core of what we do. Research and education are obviously important too, but we pride ourselves on giving excellent care to our patients, and we look at the care we give as sort of team care. You know, my patients are your patients. We try to get that mentality ingrained early that these aren't my patients that you're looking after, these are our patients. We have a very high surgical volume with early exposure to the OR. And from an overall program perspective, I mean, this program has been obviously around for a long time, but very, very stable. We have a very good administrative structure. So these things may not be sort of the top foremost in your mind, but a lot of this stuff requires good administrative support. And so we have an excellent program administrator. There's an entire what we call Office of Education run by Dr. Watterson with many other staff there who support what we do and help you with things as well. And so that's in place. And again, all the things I showed you have been around for a while. Yes, we adjust on an annual basis, but this is a formula and setup that's worked for a long time and sort of tested. And so I think that's a real strength of what we've got going here. And so Ravi, why don't you put up my last couple of slides on the frequently asked questions. I won't spend too much time because I definitely want to leave a few minutes for the live Q&A. And some of these we've sort of answered in the progress of the talk. Why don't we go to the next one? So this has been covered, I think. This is where our residents ended up, our last 6 years of graduates. If you look at the bottom line, basically direct to community, fellowship to community, and academic it's all over the map, which I think is testament to people being able to achieve their career goals no matter what they are. Next slide. We talked a lot about research and the surgeon scientist angle, and Kristen spoke a lot about this. One question I got a lot was, do we offer a master's degree as part of the residency? Currently, we do not. We don't. There is not really a surgeon scientist program here in Ottawa. You know, there's certainly pros and cons to that approach. I think pretty much everybody, and myself included, who ended up doing a master's degree and became an academic urologist did so during fellowship, and so certainly not having a surgeon scientist program doesn't take you out of the game for an academic career. And I think my bias is you're here for the surgical training and then the academic training, and for your eventual job, probably the master's, if you're going to do that, is best done as part of fellowship. I think pretty much all of us who've done it that way would agree with that. So just to answer that question very, very specifically. Next slide. Mentorship and career planning. I think this has sort of been alluded to already. We have a very supportive environment here, and a lot of our mentorship is informal in the sense that people align or find out what kind of urologist they want to be, the subspecialty, etc., and find one or more staff mentors to help them with that. Also an extremely high amount of support and mentorship between our junior and senior residents. So mentorship, how to be a resident, mentorship in terms of getting fellowships and eventual career is all there. We certainly have a lot of formal processes in place, including semi-annual meetings with our whole committee where we include a discussion of career counseling. I've taken to scheduling a meeting with our third-year residents to really, in a formal way, discuss everything. But I mean, most of that is a summary of what's been discussed informally. And we have a resident manual that has all kinds of information about it. And we've produced a timeline and checklist, things that you should be thinking about at each stage of training, PGY 1 through 5, about planning your career through residency and beyond, and some resources for that. So I think we have a good system, and as you see, some of our recent graduates have been able to achieve what they wanted to. I would say off the top of my head, I can't really think of any resident who didn't get the fellowship they wanted, for example, coming out of here. Next. This is getting into some of the more emotional questions for you, and practical ones too, about COVID. You know, I've listed here in our 3 points, this is how we traditionally assess, you know, applicants. We look at the file, we do an interview, and then we have electives. And I mean, honestly, and I think just being honest, the elective exposure was traditionally very important. I think that allows us to assess knowledge and skills and functionality and communication, professionalism, all the things that we would want to know about. Clearly, that is just not there this year for anybody, any program or any student. So even though it's not the playing field we're used to, I think it still is a level playing field in that way. And so this is, again, more talking to our process. We've, for many years, and Dr. Watterson started this when he was program director, we've developed like as objective a system as we can to assess all our applicants, who are all basically generally very good, but to assess their application packages through a variety of metrics, looking at all the categories that you're putting data into. And same with the interview. We've developed a more semi-structured interview where we try to ask everybody we do ask everybody the same set of questions, and we have a panel of us, including a resident, do that assessment. So those things are going to be the same as we've always done. And obviously the goal is to be fair, objective, and transparent. And so, you know, the absence of electives, sure, it throws a monkey wrench into our traditional system, but you know, I guess at least it's not that half of people have done electives and half have not, or something like this. Next slide. On a sort of related question that I get a lot, how can I make my application package more competitive? You know, I think if you want to enter a lifelong career in urology, which is what you'd be doing, obviously having some experience in the field is important. There are certainly similarities between urology and other surgical subspecialties. I certainly myself was interested in surgery in general, and I could have seen myself as a different kind of surgeon. Urology was obviously my first choice. So there's definitely some crossover there. I know that one of the limitations this year is you don't have 12 weeks of electives to prove that you're dedicated to the cause. Well, I've never been a believer in that anyway. I think a certain amount of exposure in one way or the other is important so that you know what the field is about. I think if you talk to most of us, myself included, what hooked us into the specialty was an experience or a mentor or an individual person in the field that we had an early experience with and then went down the track. So I mean, I think that's obvious, but I think the volume of exposure and experience is less important, and I know many of you are anxious about that. I mean, clearly we understand the situation. I think it is a challenge, you know, especially if you're uncertain about your career path, and we see this every year where some people do come late, like Dr. McAlpine, to the field and struggle with that limitation. So, I mean, it is what it is in terms of the experience you can get, but I think, you know, having some and demonstrating that in your reflection in your personal letter, for example, is important. And the personal letter, like I mentioned, which we always look at, is always nice to learn about people and their motivation. And so I think furthermore important to spend some time on that. I'm going through these very specific points, and these are my opinion for our program. Reference letters. So the usual application package I will review will have 5 or 4 reference letters, all from urologists and academic centers and from electives, basically. And so you're probably not going to have that this year. And that is fine. And that is what I'm expecting to see. And as I put in my second point there, a glowing review is a glowing review. I'll pump him up a little bit here. James Hayes, who spoke to you earlier, one of his reference letters was not from a urologist, and it was from, I can't remember, it was some kind of internist, but basically saying he was one of the best medical students she'd seen and attested to a variety of things. And to be honest with you, that kind of letter meant just as much, if not more, than one coming from a urologist. So I'm telling you this to show you that, again, put together your application package as best you can, and that all of these sorts of inputs, I think we place on a level playing field. And a lot of the things we're looking for in reference letters are not that about your urologic knowledge or technical skills. They're more about your general skills of being an active listener, eager learner, good communicator, professional, all those other things. We can teach you the knowledge and the skills, but we're looking for people with a good base as a good medical student and physician. Again, research experience in urology is certainly not essential. Some kind of research experience allows you to demonstrate that skill set, perhaps have a reference letter from a supervisor who can attest to your skills and a track record of being successful in that, but not essential. And certainly research in urology is not essential. And the last point is is difficult to do in a CARMS application package and an interview, but these other skills that I mentioned, which are things we are looking for, do your best to give us examples of these features. So certainly a tough year for you, not having necessarily met us and shown us your stuff in real life, but I want to reassure you that we're going to be very, very thorough and spend a lot of time on the work that you all put into your application packages. So these are my thoughts for you. Again, this is coming from me as an individual program director, but I think it's fair to say that these are all reasonable things for programs to look for. We can go to the next slide. Anticipate any major changes? This is another common question. Basically, nothing major. We have a very stable group of faculty, a couple of potential new hires to bolster the program we already have, a third pediatric urologist, for example, perhaps another transplant urologist or men's health urologist or oncologist in the next 3 to 5 years as just volumes increase. But we already have all our areas covered, and most of our faculty are let's say, young or mid-career. We're not having a lot of retirements coming up. Our CBD curriculum, we're in the mid phase of it now. So that's James Hayes as a third year is the first year in that. And as his year rolls through, we're opening up or going through the phases, but that's been going very well. So basically, no. How do we make changes to our program? Basically, we solicit feedback frequently. Certainly as a program director, I really appreciate input from residents. We hold meetings, especially through the COVID time, fairly often to figure out how we can work this. But even when things were more stable, if something comes up, we take the feedback and modify the program as needed. Usually a little tweak here or there to a rotation or a certain type of component of the academic schedule.